Good afternoon, and thank you for joining me for another Leadership Rounds. I'm Dr. Mindy Estes, President and CEO of St. Luke's Health System in Kansas City and Board Chair of the American Hospital Association. This week, I'm pleased to introduce Dr. Trivedi, President and CEO of Sheppard Pratt, a psychiatric hospital located in Towson, Maryland, that offers a robust inpatient, outpatient, home-based, school, and residential programs. In addition to his role at Sheppard Pratt, Dr. Trivedi is also clinical professor of psychiatry at the University of Maryland School of Medicine and a nationally renowned expert in healthcare, hospital systems, care delivery, population health, and behavioral health. Dr. Trivedi serves as editor of Psychiatric Clinics of North America and is the author of Practical Child and Adolescent Psychiatry for Pediatrics and Primary Care, as well as serving with me on the board of the AHA, the National Association for Behavioral Health Care, among several other organizations. Hirsch, thanks very much for joining us today. And so let's just jump right into it. As I look back over these last few months, what impact has COVID-19 had on the behavioral health of your community, and what trends in general speak to the need for enhanced behavioral health services in America?
Mindy, thank you for having me here. And I think, when I look at COVID right now and I look at the community, stands out to me is just how much people are struggling. I think between the combination of health effects, what people are experiencing in terms of kind of disruptions of normal routines, and then kind of financial sequelae, it is impacting every part of our society. And so the things that I see and the things that I think about are really, we have this case counter that's on about, we've had 160,000 people die from COVID. Experts are right now predicting that in the next year we'll have about 200,000 people die due to COVID-related mental health issues, suicide, and overdose. And so that's a public health emergency that we haven't even started talking about. The other thing that sticks out to me is just what we're seeing right now. We are based in Baltimore, but we are throughout the state of Maryland. We run the domestic violence shelter right outside of DC, and we're seeing such a dramatic increase in domestic violence and child abuse cases. We're seeing upticks in substance use and relapse in terms of substance use, and so people that had good established protocols, they were going to their AA groups. Those groups, when they went virtual or maybe stopped, those supports are gone. People have more stress. We're seeing a lot more relapse. And then the other thing that I'll just say in terms of these different things is we're seeing a much broader segment of society needing behavioral health services. It's not simply people that had histories of mental health problems. We're seeing people that have never needed care before now coming in and needing help, including our own healthcare workers.
It is a crisis that we don't talk about much yet, but I agree with you. I think as we move into the next time frame, it will be perhaps the unspoken crisis of COVID-19. How has your organization, Sheppard Pratt, adapted during this time? I mean, do you have any new or expanded services that you've initiated or innovations that you think may be here to stay?
Well, I think there are definitely some innovations that we've done, and we hope they're here to stay if the regulatory and payment mechanisms continue. And so, one of the big things I would turn to really is we have had to rethink every part of our organization. We have 387 locations in which we have services. And when you think about something like COVID and not being able to have face-to-face interactions in behavioral health, we've had to redo everything. So a lot of our outpatient services we've converted fully to telehealth. We just finished, I think, our 110,000th telehealth visit for behavioral health. We've started a brand new virtual crisis clinic. So it's kind of like an urgent care that you do via telehealth. And then what we do is we try to figure out what people need, get them connected to the right services, and then if need be, we also offer transportation so that people don't have to go to the emergency room or be in other places where they may be concerned for their own health or exposure to COVID. Other things that we're doing, I will just say, is we've had a substantial more focus on social determinants. Just in our last 3 to 4 months of kind of COVID in Maryland, we have prepared and delivered a 250,000 meals into the community. And so it's a whole host of different things, but I think fundamentally a lot of the model is shifting. And I think that the biggest thing we're hoping for is that telehealth becomes permanent, both in terms of regulatory waivers going away, as well as hopefully having some parity in terms of payment so we can keep on providing services that people need.
How challenging is inpatient care in this time?
It is incredibly challenging. We operate 19 different inpatient units, patients of all diagnoses, all different types of ages as well. And I would say, we have fundamentally shifted the inpatient model of care. We actually had I think a great AHA webinar previously on that topic. And, we've had to think about, mental health generally on inpatient settings tends to be a lot of congregate care and people in groups and talking to each other. And we've had to completely shift that. So right now in our hospitals, we don't have visitation by family. We do a lot of virtual family meetings and those types of things. As we think about groups and other things that happen on the unit, a lot more time is individual. And so how do you get the same amount of therapeutic benefit? And then we also just think about how do we make sure that we keep on providing access? Many hospitals across the nation, particularly those that have semi-private rooms, have had to decrease their census. And so for us, making sure that all 19 units stay open is particularly important. And as a part of that, making sure that our emergency rooms don't get backed up with behavioral health patients is also important, so we can make sure that we are meeting all the COVID-related needs of our community.
You touched a little bit earlier, Hirsch, on this, but now more than ever, it really is important to foster resiliency among our physicians and frontline caregivers, and actually, I dare say, our administrative folks as well.
Yeah.
What suggestions and recommendations do you have to minimize burnout and help strengthen the resilience of our workforce?
Yeah, so I think this is probably going to be one of the most fundamental questions that our organizations need to ask. And why I bring that up is because I think the thing that is fundamentally different about COVID compared to everything else is we're all trained in healthcare. We naturally, instinctively run towards fires. Well, this is the one disaster in which, as we go in, our healthcare workers are concerned about PPE, they're concerned about their safety, they're confronting their own mortality as they go to work every single day. And I think that enters into the psyche in a very different way. And I think as I think about resiliency, there are things that we have to address as organizations. Some of the things that we hold in great valor, and I'll say for you and I as physicians, we're proud of how hard we work. We're proud of how many hours we work. But our organizations do things like, we have people returning emails on the weekend. People have lost that balance between work life and home life. And what does that mean? So the things that I would say we have to really think about is, how do we truly get our folks to understand that this really is a marathon? How do we give people the permission to turn off their device, not chart late at night to catch up on their notes for the next shift? How do we get to, one of the things we've done is we've converted our staffing to be 7 on, 7 off. Yes, for COVID, but also because people need some downtime to rest their brain. And then the other thing that I will just mention is I think, we need a new model for EAP. And I guess what I'd say in that is we really have to shift towards more of a public health focus. We do a lot of training and providing resources to the entire organization. And then we kind of narrow into specific people that may have more of a need. And we connect them to whether it is group-based, talking about what's going on, or connecting people to direct care. And the one thing that I will say is, on the administrative team, and especially on the clinical teams, as well as a lot of the support services, many hospital CEOs have spoken to me about, we had a near miss. This person was contemplating suicide. I was really concerned about this person on my team. We have to stop and really make sure that our folks are okay.
Yeah, I agree. We're going so fast. We're all so tired, but yet the ability to stop, to take a moment and to encourage talk, to encourage sharing of experiences, because I think we are all feeling the effects of this long stretch of time here.
Agreed.
There were severe shortages of behavioral health workers before the pandemic, and I can only assume that this has worsened. How do you think this shortage of behavioral health workers impacts the inequity of care that we've seen during this pandemic?
Yeah, one of the difficulties is that we're all aware of kind of the variations in COVID positive rates, hospitalizations, or even deaths by race. And I think when you get to the behavioral health piece, there really is a similar trend in terms of minority communities not trusting or not feeling comfortable accessing mental health services. On the workforce side, there is a racial divide in the sense that we do not have equal or equitable representation of the communities that we serve within the professionals that work within our teams. And particularly on the workforce side, I think one of the difficulties is we know that a major surge of need is coming. And because of, I think, the whatever is that time it takes to get someone into the field, it's going to be tough to meet the existing demand unless we think about different ways of providing care, but also getting more people into the mental health workforce, and specifically from some of the more underrepresented minorities that we need to have in these settings.
So it certainly appears the pandemic will continue. And as we look ahead to the fall season, and I think a fall season that many of us are quite worried about, and even beyond, what messages do you feel are crucial to share with your local community, and how can we enlist them to become an active part of the solution?
I think one of the most important things here is really, I talk often within my organization and across my community to say we have to check in on one another. This is a long road, and many times the people who are doing the worst are the ones who actually have the facade up. You look at them, they look happy, they look smiling, they may even say some positive things to you. But if you stop them for a moment and you just say, how are you doing today, Mindy? Looks like you might have had a bad day. Looks like something's going on. Or sometimes, just asking how are your kids doing, and people will say how they're feeling. And I think checking in is number one. The second thing is our best chance of getting through this is together and supporting one another. And I think that has to happen not just within healthcare, but across all of the different places in which we hold roles, as well as our parts of our community. And then the last thing I'll just say is we really need to work on making it okay for people to talk about the challenges they're having, whether they're mental health or substance abuse or anything else that may be going on, financial or otherwise. Because many times it's that perception of I've got no options left, there's nowhere to turn. That's the moment where someone thinks about suicide. It's the moment where someone maybe has an overdose. And we don't need, in addition to everything else that's going on with COVID, 200,000 more preventable deaths in the next year.
Hirsch, thank you very much for joining me today for this topic and conversation that's really so important to so many of us today, not just professionally as we work with our patients and colleagues, but also, as you've highlighted, for our own personal need to care for ourselves and for our families and as active community members. I know that this is a topic that can benefit everyone listening. And I want to encourage anyone who may be struggling with feelings of anxiety or depression to reach out to someone who can help. Reach out, as Dr. Trivedi said, and talk to somebody. Reach out and don't be afraid to acknowledge that this is a very tough time. You can also visit AHA.org and AHA's Physician Alliance website for additional resources that are focused on stress, coping, and mental health for healthcare workers. So until next time, I want to thank everyone for joining us today. Hirsch, I really appreciate you taking the time to give us some strategies and to highlight for us what all of us have responsibility to do. I hope all of you will be back for our next Leadership Rounds conversation, which is on August 27th with Rochelle Schultz, President and CEO of Winona Health in Winona, Minnesota. So until then, stay safe and be well. Thank you very much.
Thank you.